Look at this model of the heart's electrical system. High up in the right atrium sits a tiny cluster of cells called the sinoatrial, or SA, node. This is your body's built-in primary pacemaker. It fires a continuous series of electrical impulses down specific pathways, commanding the muscle tissue to contract. As those signals cascade through the tissue, the electrical command translates into a physical squeeze. Under normal conditions, the SA node keeps this mechanical pump running at a strict, steady rhythm of 60 to 100 beats per minute. That precise timing dictates how much blood leaves the ventricles and enters your circulatory system. Every organ in your body relies on the SA node maintaining that exact tempo to receive a constant supply of oxygen. If that tempo falters, oxygen delivery plummets. Any deviation in the rate, rhythm, or origin of those electrical signals creates an arrhythmia, directly threatening blood flow and human life.
The system can fail in several ways. Ischemia, electrolyte imbalances, or structural damage can cause rogue cells outside the SA node to start firing on their own. Signals can get trapped in endless loops, or the tissue can lose organization entirely, quivering chaotically instead of generating a uniform pump. When cardiac output crashes, the brain begins starving for oxygen within seconds. Medical professionals arriving on the scene do not have time to sit and ponder the underlying pathophysiology. They rely on a globally recognized protocol known as the Advanced Cardiovascular Life Support, or ACLS, algorithm. It is a highly structured decision tree designed to quickly categorize the exact type of electrical failure and match it with the correct intervention. This structure ensures that under the extreme pressure of a code, every clinical intervention is a calculated response driven by the patient's specific physiological feedback. This diagram shows the first major fork in the ACLS cagme. The algorithm splits arrhythmias into two basic categories: rates that are too slow, under 50 beats per minute, and rates that are too fast, over 150. Moving down the slow branch, or bradycardia, the protocol immediately asks a triage question. Is the patient symptomatic? If they are showing signs of shock, acute heart failure, or altered mental status, immediate intervention is required. The first line of defense is chemical. A drug called Atropine is pushed rapidly into the IV. Atropine works by blocking the vagus nerve, lifting the body's natural brakes off the heart and artificially accelerating the SA node's firing rate. If up to 3 milligrams of atropine fail to increase the heart rate, or if the electrical block is too severe, doctors must escalate beyond drugs to transcutaneous pacing. Transcutaneous pacing shoots electrical currents directly through pads on the chest and back. The machine fires relentlessly, acting as an artificial SA node. When the heart's natural clock slows down to dangerous levels, emergency medicine relies on pharmacology and external electricity to literally force the pace. On the opposite side of the spectrum is tachycardia. When the heart rate pushes past 150 beats per minute, the ventricles beat so rapidly they do not have time to properly fill with blood between contractions. Returning to the diagram, we hit another crucial fork in the fast pathway, assessing stability. Is the patient stable or unstable? If the rapid rate is causing hypotension, ischemic chest pain, or a total loss of pulse, there is no time to wait for intravenous drugs to circulate through a failing vascular system. The only viable option is electricity. If the electrical rhythm is unstable but still organized, meaning the ECG shows a distinct, repeating pattern, providers use Synchronized Cardioversion. Look at how the machine targets this pattern. The defibrillator reads the rhythm and times a precise, low-energy shock to land exactly on the peak of the R wave, the moment of ventricular depolarization. Hitting this exact window avoids shocking the heart during its vulnerable reset phase. But if the rhythm is completely chaotic and the patient lacks a pulse, like in ventricular fibrillation, precision timing goes out the window. The protocol mandates unsynchronized defibrillation. Defibrillation delivers a massive, instantaneous dose of electricity to simultaneously depolarize every single cell in the cardiac muscle at once, wiping the slate clean. When extreme heart rates push a patient to the edge of collapse, providers bypass the pharmacy entirely. They use raw electrical force to trigger an immediate system reboot. If a patient is tachycardic but their blood pressure is holding steady, the situation is stable. This buys time for a more calculated approach using specific antiarrhythmic drugs.
For fast rhythms with a narrow QRS complex on the monitor, like Supraventricular Tachycardia, the problem often involves a signal looping endlessly through the AV node. The goal here is to break that circuit. The primary tool for this is a 6 mg rapid intravenous push of adenosine. Adenosine works by temporarily blocking electrical conduction through the AV node entirely. As you can see on this monitor trace, adenosine produces a highly stressful side effect. By blocking the AV node, it essentially stops the heart, causing a few seconds of flatline asystole before the natural pacemaker takes back over. If adenosine fails to break the loop, or if the rhythm is atrial fibrillation, providers turn to other rate-controlling drugs. Medications like Metoprolol, a beta blocker, or Diltiazem, a calcium channel blocker, suppress the AV node to slow the ventricular response. However, if the monitor shows a wide QRS complex, the abnormal rhythm is likely originating deep within the ventricular muscle tissue itself. These rhythms, like stable ventricular tachycardia, require heavier pharmacological intervention. The algorithm points to amiodarone. This drug acts as a broad-spectrum blockade, inhibiting potassium, sodium, and calcium channels simultaneously. By slowing down the flow of these ions, amiodarone forcefully prolongs the time it takes for cardiac cells to recharge. Stable tachycardia is managed by deploying specific chemical resistors that tune the heart's electrical timing, avoiding the immediate need for electrical brute force. Film sets are designed to capture the high-stakes intensity of a cardiac emergency, where every second is treated as a moment of frantic improvised drama. In clinical reality, that improvisation is replaced by the ACLS flowchart. It is a relentlessly logical framework that functions as a corrective to the chaos of a crash. There is no guessing. The entire response hinges on answering simple, binary questions. Is the pulse fast or slow? Is the patient stable or unstable? Is the QRS narrow or wide? The specific treatment, whether it is pushing 3 mg of atropine or delivering a 200-joule shock of electricity, is just a tool to serve a single underlying objective. The objective is simply to silence the rogue electrical chaos long enough for the heart's rightful master pacemaker, the SA node, to wake up, reassert dominance, and resume the normal rhythm. Restoring a failing heart is an exercise in applied electrophysiology. It relies on a highly engineered, step-by-step algorithmic science to hit the reset button and pull the life back from the brink.